Okay, this is an interview with Philip King at the CQC. Hi Philip, thanks for agreeing to be interviewed for us.
You're welcome.
I think our readers will be interested to know how someone who trains as a nurse ends up at the CQC. So can you tell us a bit about your background, please?
Yes, so I trained as a nurse in the 1980s in the West Country, working in mental health. And I worked in community mental health posts for a few years in Somerset. Then I moved to London and I worked as a community nurse here originally and ended up working in various advisory nursing roles in central London. And I then decided that I would go and do a law degree.
Now, why did you do that? Because it's not a very traditional route, is it?
No, it's not, and there were two reasons. First of all, I ended up in various management roles in mental health, and as your readers will know, you get to do more and more that relates to the law. Everybody practices with, if you're a nurse, but particularly a mental health nurse, within a very regulated set of functions. One day I found myself giving evidence in an employment tribunal. I unfortunately dismissed a member of staff, and I was talking about this in my office and talking about how I thought that the lawyer representing various parties could have done a better job. And my secretary eventually got so fed up with this and said, well, if you think you can do any better, why don't you?
Put your money where your mouth is.
So I thought, yes, I will put my money where my mouth is. So I went and did a law degree. I continued working in the NHS at the same time, and then thought, well, this is very interesting. I worked mainly in areas relating to law and mental health, so I was a policy advisor with the Law Society for a while on mental health law, and I practiced at the bar, dealt with HL, which was the Bournemouth case, was involved in that in some ways as one of the junior lawyers involved in that, and enjoyed it very much. But actually after a while, and I remember the mental health advisor for the RCN at the time saying, you'll be back.
Is that Chris Allen?
It was Chris Allen. And he said, you'll be back. And I said, no, I don't think I will. I'm going off to be a barrister. And he said, I'll give you 5 years. And 5 years to the day, I ended up working for the Royal College of Nursing, and then went back into worked for the BMA for a while, and then went back into the NHS in both a nursing role, so I was a director of nursing, and also using my other skills around governance.
What sort of preparation did being a nurse give you for when you were a barrister? Because it sounds a completely different kind of job.
There are significant differences, but there's also an awful lot that's transferable. So to be a barrister, you've got to be quite resilient, and you've got to be able to think on your feet, and those are qualities that you most definitely get training and working as a mental health nurse. So absolutely important. Interpersonal communication, how to form and maintain relationships with people who don't necessarily trust you or anyone else. Direct correlation for me, because I was working predominantly with people with mental health problems who got into various trouble with the law in various ways, and also the ability to communicate quite effectively with very diverse groups of people. So one minute you're up there arguing with a judge, the next you're addressing a jury, the next you're having a conference with somebody who might be quite mentally unwell. So it was very good preparation. One of the difficulties with being a barrister is that when you've done your case, you move on to the next one. So one of the things I missed was the ability to make sustained improvement, which you can only get working in public service directly, I think.
And did you only deal with mental health cases?
Mainly mental health, some disability cases. Developed a specialism around those areas, but no, did some criminal law as well, which is very interesting. Fascinating stuff. I love the law. I'm not too sure about lawyers, but I love the law.
So what's it like working for a regulator? I imagine it's a pretty pressurised environment.
It is. I mean, I don't think it's any more or less pressurised than anyone else's job, actually. And I think back to when I worked in the NHS leading nursing, for example, that had its pressures as well, as did, we'll go back to being a community nurse, that had very different pressures, but just as pressurised. Admittedly, it's a different level, it's a different scale. It's great in many ways because I think in order to be an effective regulator, you need to be an effective regulator in public service and health and social care. You need to really believe in what you're doing in terms of the improvement of services and be very much passionate about the quality of services. So you get that. If you've been a nurse for a while, then that absolutely is on point. I think it's very useful to have contextual understanding of the work that people do, understand how the system works. But secondly, you need to have a fairly good understanding of how that translates into hard-edged regulation as well, which being a lawyer really helps with.
I know you said that you've got two aspects of your work. Can you say a bit about those two different aspects of your work, please?
So I'm Director of Regulatory Development, and what that means is that I deal principally with regulatory policy, so working with other organisations, also advising our own organisation about how health and social care should affect regulation, and regulation should affect health and social care. Within that also I have responsibility for designing the methodologies and the ways in which we look at regulating. And I've got a substantive role around oversight of our, we've got some statutory functions about involving people who use services, not just in the regulatory process, but how we regulate overall. So if we decide we're going to do things in a different way, we're going to have a different way of inspecting, then we must involve people in thinking about how that works. But also some of our responsibilities in terms of qualities and human rights. The other side of my role is that I've got responsibility for the aspects of the Mental Health Act which the CQC runs. So that's regulating against the Mental Health Act, but also thinking about the Mental Capacity Act, deprivation of liberty safeguards. So people will be familiar with the visits of our Mental Health Act commissioners coming and visiting, looking at the conditions of detention and the legality of detention of people detained under the Mental Health Act. And also your readers will be familiar with second opinion approved doctors who will come and give a second opinion about somebody who's detained under the Mental Health Act after the first 3 months of their treatment, will often need a second opinion and in other circumstances. So that's part of the work that I work with. It's very interesting. We've got a very diverse workforce. So we have lots of external experts who work with us on a part-time basis, which is very enriching for us as an organisation. And we've just had a public consultation on our future strategy and the way the organisation will work in the future. And there are 6 main things that we're going to look at. One of them is about making sure that we strengthen and promote mental health and mental capacity as a central function of the CQC. As people are probably aware, the Mental Health Act Commission used to deal with those things. There was a merger of 3 organisations, and we feel now it's really important to make sure that mental health is at the centre of much of what we do.
So are you involved with, presumably not hands-on, but in the training of the inspectors?
Yes, so we would look at how we're going to do that when we're devising different methods and ways of whatever the best way of regulating something is that we'll work with colleagues to think about how best to do that. I was in fact doing a training session myself about 8 weeks ago on mental capacity, but it's not something that I would normally do it day in, day out, but it's something that I think is very important, and we're just about to, as an organisation, do significant training for all our staff on dementia. So whether you're an inspector or whether you're somebody in a supporting function, we think it's really important that everybody has an understanding of dementia, because it's an area that we come across all the time when talking to people about the services they receive.
So are there going to be any big changes to the way that that regulation happens in terms of your inspections? Because that's the kind of interface where our readers are likely to come across the CQC, I guess.
So at the moment we inspect all services against a common set of standards, a common set of regulations. And our inspection workforce they're generic in the way they work, so they may be looking at an acute hospital one day, they might be looking at a care home with nursing the next, or indeed domiciliary care or general practice. We're looking at general practice from April onwards. One of the things we've discussed in our strategy review is, should we have more of a differentiated way of looking at services?
Depending on the type of service?
Depending on the type of service,
right.
Looking at what's important for that service, for the people who receive those services particularly. Inevitably thinking about what expertise we need to do that. So we've just closed our consultation, and we'll be publishing our response to that in the next few months. We're not looking to make immediate changes in that period, but that's, we will certainly look at those, what people have said to us, very seriously, to think about over the next 3 years plus how we can be more effective as a regulator.
And obviously the CQC's hit the headlines over the last year because of Winterbourne View.
Yeah.
I don't particularly want to go over that, all of that original story, but I'm guessing that there is going to be a fallout from that, and things are going to change because of Winterbourne View. Can you say a little bit about that, please?
Yes, I think certainly. In response to Winterbourne View, one of the things that we did very quickly was to have a national inspection of services that offered assessment and treatment for people with learning disabilities, and we're going to continue making learning disabilities a particular focus of our work. Because of the nature of the service, when we talk about differentiation, one of the things we need to consider is the vulnerability of particular groups of people. So people with learning disabilities and the services they receive will be a top priority for us. I think it's also fair to say that we're working very closely with the professional regulators, with the NMC and the GMC, to make sure that we're working together, because it's important that as a sector regulator, where there are issues of professional and clinical practice, we need to be making sure that we're sharing information and working collaboratively with the professional regulators. And inevitably there may well be some changes to the way we regulate, to the duties around quality of care that we've placed on providers, and that's something that we'll work with stakeholders, with the sectors, to develop as we go forward.
The government's final report on Winterbourne View looks like it's going to completely rewrite the rule book in terms of how people with learning disabilities are going to continue to be cared for. Assessment and treatment centres are going to close, effectively the hospital type places can close, and people will be in, I suppose you could say, houses, normal houses, I guess, with support.
Yeah.
Is that going to put an extra burden on inspectors, do you think?
Not necessarily, because I think the important point here is that one of our founding tenets is about the quality of service. And it's very clear, I think, from professional colleagues who work in the area that there are models of good practice. You've described them to a certain extent there, about the need for intensive support in units that are appropriate, that are not institutional, that deal with personalisation. We would endorse that. And it's important that we will continue to inspect around the quality of those services and what's right for people with learning disabilities. We are now far more reactive around safeguarding concerns and whistleblowing, and we have dedicated phone lines and areas of our website where we encourage people to let us know about the concerns that they've got around services. So I think it was a dreadful situation. I think clearly particularly distressing and awful for the patients and their relatives, and I think everyone in the CQC is very mindful of the need that we need to continue to be more effective in our regulation of that area, and I think clearly providers are perfectly aware that they need to improve the care that they give, and we will hold people to account for that.
Is there any scope for some form of self-regulation? I'm thinking about schools. If a school has a good Ofsted report, it knows that it's going to have fewer inspections, and there's a kind of self-regulatory system built in. And I know that universities, whereas it used to be the English National Board used to oversee the courses, it's now kind of devolved down to the universities. Do you see any scope for self-regulation?
We've got a very clear statutory mandate around regulation, and certainly the indication we have from from government is that's not going to change as our principal way of working. I think we would welcome organisations that voluntarily offer up particular ways of ensuring quality. Then that's very helpful. It wouldn't necessarily replace what we do. I think self-regulation is a difficult area. One talks about Ofsted, but of course a school is not a hospital. There are very different stakes involved. So I think it's very clear that our role will continue to be the independent regulator of that, although we would want to see organisations that are regulatory minded, that want to demonstrate that they are providing high quality of care, that they've got the right culture of care, that they've got the right leadership of the organisation. So we'd very much welcome that, and organisations that weren't interested in that, we would equally be interested, because we'd want to know how the organisation is going to ensure that when it provides care that it's doing the very best that it can.
So part of good governance would be that they would know well enough what their services are, so that you wouldn't be telling them stuff they didn't know. No surprises.
Exactly, and that governance isn't a kind of a separate process. The governance meets up with people's expectation and people's experience of the service, and they meet together, and as well as what staff tell us about services. Very often it's our experience that nurses in particular will come in and say, we're very glad you've come, because we want to talk to you about the quality of these services. We want to highlight what we think is good, and we also want to tell you what we're trying to do to improve things. And that's a good organisation. It's one that's open to us being involved, and they see our looking at services as an additional level of assurance for the people receiving those services. Our concern is where organisations aren't transparent and don't want to improve necessarily, or don't see the need to improve. That makes things more difficult, and obviously would cause concern.
In a way, I think nurses feel that they're a bit stuck in the middle, because they seem to be under scrutiny more than ever before. I think that's fair to say, and yet they're working in an environment that's very tough out there. You know, whatever the numbers are, there are fewer nurses working now than there were a year ago, 18 months, 2 years ago. And do you have any sympathy for them in that kind of position? Oh,
I have huge sympathy. I think obviously the RCN have published their own survey on the cuts in frontline nurses. It's not really for me to comment on that, but I do recognise that, you know, in very difficult circumstances, and it is very testing times out there, it can be very difficult for nurses. There's certainly welcome the Chief Nursing Officer's initiative around the 6 Cs. I think that's really helpful. My experience is that the majority of nurses are thoughtful, professional people who want to do the very best they can. I think I've certainly been in positions where I've had to, put my ethics and my professionalism first, above what the consequences might be. That's the mark of a true professional nurse, and we as the CQC would be looking for professionals to speak out wherever possible, not just nurses. But I don't underestimate that can cause some sleepless nights for people. But at the end of the day, one only has one nursing registration, and it's important to abide by the principles of the code of conduct, and to think about what's the best for one's patients.
If the CQC came across organisations where they could see that the standards weren't being met, but they could also see that one of the reasons was because there weren't enough staff, or staff weren't adequately trained or adequately supported, what could you do as a CQC?
I'm not necessarily going into a debate about resources, because that's got a political context
I understand
to it.
That.
But I would say that I think, to be very clear, we come across organisations that are geographically close to each other, that have very similar demographics, and often have similar commissioning arrangements, and yet the quality of service is different. So it's not just about the resource. There is something there very clearly about quality. I'm not saying there's not a relationship between resources and quality, but at the end of the day, we have to be concerned about the quality of the service. We may comment on commissioning, but that's not our role. What we'd want to do is work with commissioners, because it's important in the new landscape in the NHS that we're working alongside not just other regulators but other system players in health, to look at improvement, and all the signs we've had from the commissioning board are that they are all equally as interested in quality and how that affects commissioning, and we want to make sure that we were aligning our principles with them so that we can improve the quality of services, and that's what providers want to do as well. But there is certainly, there's more to variation in quality than simply the check at the end of the day.
Sure. So you mentioned the word culture earlier. Can the CQC influence the culture in an organisation, do you think?
Yes, I think we can. I think that we certainly recognise culture as a significant area. So as I said earlier, it is unfortunate. I think any organisation that were to say we couldn't fail on quality or standards or whatever is being a little naive. I think it can happen anywhere for a variety of reasons, not necessarily intentional or conscious. I think what's important is what organisations do about that. I think many organisations will recognise they have an overall good standard of care. There might be particular areas within a large organisation that aren't as good as the others. So that would be another example. What's important to us is what people want to do about that. So, of the organisations we regulate, roughly around 25% aren't complying with the standards, but a very, very, very small number of those do we actually take any enforcement action against.
Right.
Because the majority of organisations see the importance of improving. Whether that's because they know that there's an end game to that, and we do have regulatory powers, and we do use them, or if it's the fact that actually they're being far more open, and this is where the culture point comes in, Colin, that you've made. Organisations that understand quality issues and where there are problems they want to improve, where there's transparency and where there's clear leadership on quality, not just on the cost of care, are the organisations that in our experience are more receptive and more effective at changing. Those that wish to argue about it are often more problematic.
And that raises alarm bells with you?
Certainly I would be concerned where we've got clear evidence of a failure of service and the organisation is not accepting that and is investing their time in saying why it's not the case rather than looking at how they can improve. Straightforward but an important maxim.
Yeah, and there's a threshold. Is it people have to reach a certain threshold? Organisations have to reach a certain threshold?
So certainly they need to be compliant with our essential standards. The essential standards are not minimum standards. They're essential. And they are quite broad ranged, but if you look at them, they're all based on our regulations, and very clearly they are the kinds of things that, for example, your readers will recognise from nursing practice. It's about, for example, involving people in their own care, looking at negotiating care planning in a way that's effective for people, good medicines management, having systems for safeguarding. How do organisations learn from mistakes? Is there a proper understanding of quality and the need to improve from the board of an organisation as well as from the ground floor? So those are things which aren't new or different and are really the hallmarks of an effective health or social care organisation. I went on an inspection recently where I went into the changing room and on the back of the changing room in a surgical unit it had a note pinned to the back which was, if the CQC come, these are the questions and these are the answers. Absolutely the wrong end of the telescope. What we're interested in is identifying what good services look like and highlighting where people need to improve. Very often we'll know some of that before we go in because we use an intelligence-driven risk model. But sometimes it will be what patients tell us about on the day that we might follow up. So there are no absolute questions and absolute answers. It's not an exercise in reviewing governance documentation. We're not going to look at that in the first instance. We're going to talk to people about what the services are like, what people are experiencing on the ground, what staff tell us are the issues, what our own inspectors understand from what they see and hear and touch and smell. We might look at the systems if there are issues with that to try and gain a greater understanding. In fact, we very often will. But so it just demonstrates to me the importance that a well-regulated organisation is a high-quality organisation. We're not asking people to do anything that is any different to what people would expect for the services that run at that level. So obviously we're about to see the friends and family test come in. It's a good maxim. Is this service fit for my friends and family? That's what we'd like to see.
And the note on the back of the door kind of crystallises that kind of glib approach to it, isn't it? That, okay, these are the right answers, rather than this is the right kind of service.
Yeah. This is not a tick box exercise. Yeah. This is about good quality services that are safe, and that people... So if you think about Lord Darcy's definition of quality, it's absolutely that. It's about patient safety, it's about patient experience, and it's about effective services.
And so it's a massive kind of remit, but your inspectors have to manage to do that in a short period of time.
Yeah.
In quite a big organisation.
Yep.
What sort of systems have you put in place so they can do that? I mean, I'm not suggesting they would have a checklist.
No.
Presumably there must be some processes that they know they're going to have to do in every situation.
That's right, and at the moment we inspect those services in a particular way. As I said, as part of our strategy review, we're looking at how we're going to do that differently in the future. That won't change immediately. We want people to... We'll be looking at some incremental change, I'm sure. In reality, our staff are incredibly hard-working, incredibly able, and want to provide the right balance between covering as many services as possible, but also providing a high-quality service. So it is a challenge, but they do it well, and they're proud of it, and I'm proud of them. I'm proud of the work they do.
Can we talk a bit about your Mental Health Act responsibility?
Certainly.
Can you say again what that role is specifically?
So that's I have responsibility for managing the work of our Mental Health Act commissioners and the work of our second opinion approved doctors particularly, but also we've got statutory responsibilities around producing the annual Mental Health Act report and also monitoring the deprivation of liberty safeguards that arise from the Mental Capacity Act. So the Mental Health Act functions people will be familiar with, certainly from a mental health nursing point of view. Anyone who's detained may well be visited by a commissioner. We'll look at everything from the paperwork to the patient experience. We'll look at things like legality of detention, but we'll also look at whether people are involved, whether they're treated with dignity and respect. I think good providers, good mental health nurses know that those things are just as important, even if you don't have the range of choice that you might otherwise have if you were a non-section, non-detained patient than others. But we're also very keen to make sure that the human rights safeguards are there for people. So hence the work of our second opinion approved doctors as well.
And how's it going? You've got a report coming out soon.
We have. It's a mixed picture, if I'm honest with you, Colin. So it's this organisation's third annual report, and we've identified there have been some changes. There's some examples of really good practice, but there are still concerns. So there's a rise in this year, with last year we're reporting on, a rise in the number of detentions. The previous year we saw a rise in the use of the Act, but it was mainly community treatment orders. This year it's community treatment orders and people detained in hospital. There's lots of people who will give you academic answers as to why that might be. For us it's important, and it's important for providers, for society generally, because there are more people who are being detained and potentially treated in ways that they don't consent to.
And I mean, community treatment orders, there are many more than people anticipated.
There are. Certainly the number far outstrips the original estimates, and we have seen a year-on-year rise in their use.
Is that a concern?
I think the importance, both with community treatment orders and with people detained under the Mental Health Act, is that the legislation provides a framework for a necessity. Sometimes it is necessary for people to have their liberty or their rights restricted in order for them to receive assessment or treatment. What's important for us is that the safeguards are there to make sure that those aren't used in a way that is excessive or disproportionate or unlawful. And so we do see, and we continue to see, things like blanket restrictions on people, and actually whether that's
So like locked wards?
Locked wards, for
Yeah.
example. Other examples would be people being restricted from being in their own bed areas, for example, locking people out of their bedrooms,
Sure.
a lack of choice around things like food, around visiting times, meal times, a lack of involvement in their care, concerns around dignity and respect particularly. There's a good maxim, the mental health strategy from the government is nothing about me without me.
Yeah.
And that applies in terms of decisions people have to make.
Mhm.
No decisions about me without
Mm.
me, even if you are detained. And that's about the ability to treat people as individuals. In some ways, I would say it applies more to people who are detained than those who are informal patients, because it presents a greater challenge, and therefore it's more important to make sure that people who are subject to restrictions are treated in a way that's humane and personalised, rather than the kind of blanket restrictions that you've talked about.
Mm.
An argument I've certainly heard raised is that a locked door doesn't make it de facto detention. Well, that's true. If proper systems in place to allow people to go out, that's fine. But our concern is when it goes deeper than that, when you find that there's a culture, we're back to the culture again, that means that people don't have choice, that people can't appropriately challenge the decisions that have been made, where they don't have access potentially to things like independent advocacy services. And those are examples that we see. And that continues to concern us, and we will be going back to providers this year, and we'll be looking at those examples where we've had concerns, and if necessary we'll not just be looking at it through the lens of the Mental Health Act, but also our compliance powers as well under the Health and Social Care Act, which have more teeth,
Right.
effectively, because it's important that there is improvement. This is probably one of the most important areas for our society, and yet, although there's been greater visibility of mental health problems through things like Time for Change campaigns and others, still mental health and learning disabilities are areas that are hidden from many people. So it's really important through vehicles like the Mental Health Act Annual Report that we highlight where the concerns lie, where the improvements need to be made, but also pay tribute to organisations which have improved. The reason we talk about good examples of practice is not just because we want to be kind, it's actually about demonstrating how organisations who aren't up to scratch, that there are examples where people have got very similar challenges, where improvements taken place.
I mentioned that the CTCs and the numbers are much higher than people anticipated, and the deprivation of liberty safeguards seem to be used much less often than people anticipated.
Yes, there's it's a very interesting and complex area, deprivation of liberty safeguards. The legislation, the Mental Capacity Act, is a good piece of legislation. I think the feedback we hear, of course, is that deprivation of liberty safeguards are quite complicated for some people. They've got wide applications, so by nature they don't necessarily apply in hospitals as much, or certainly not in mental health hospitals, certainly not when people are detained. If we think about the number of care homes in the country, there are estimates of anywhere between, depending which organisation statistics you look at, that people in care homes with and without nursing, anywhere between 50 and 80% of people are suffering with a degree of dementia. And potentially deprivation of liberty safeguards could apply to all of those.
Yes, because it could be in their interest
Yes.
to keep them safe.
Yes, and we see very wide variation. We see parts of the country that make lots of use of deprivation of liberty safeguards, and certainly in terms of the involvement of primary care trusts, of course, will be defunct from April. But local authorities will continue in the role as supervisory organisations. Very different usage when you go around the country. So that is a concern for us, because sometimes they're not being used enough, because it's important. Again, it's another safeguard. So if we're less concerned about overuse and more concerned about underuse potentially. Our report is coming out on deprivation of liberty safeguards within the next few months, so very happy to give you another interview about that.
I'd be very interested to see how that goes. I just want to ask you how you, really about you as a nurse and a barrister as well, and not so much about your role in the CQC, but the Mental Health Tribunal was held in public. for the first time.
Mm.
I wonder whether you see that as a positive development.
I do. I think there's something about, well, I think for a number of reasons. I mean, I've always been a fan of legal processes being in public. I think it's an important principle. And I think just because you're detained under the Mental Health Act doesn't mean that you shouldn't have that right as well. Clearly there are going to be times when it's not in the person's interest, so they're so ill they can't make that decision for themselves, and it might not be appropriate. The content of some hearings that I've been involved in is somewhere where you would apply not to have it heard in public. Well, that would be the same as any other court hearing. So I think the hearing of cases in public is important. I think it's the person's right to have that. If there's a good reason why not, then there's a legal framework in place for protections for the individual or anybody else who might be named in that to have for it to happen behind closed doors or in the absence of reporting, for example, and that's right and justified. So generally I think it's a good thing. I think it provides a transparency to the public, which is important. I think the public need to know what happens in all legal areas. It's about part of citizenship, if I'm frank. And I'm not sure that the average person on the street knows that there is even such a thing as a mental health review tribunal. And it might be helpful for them to understand that what happens in those processes.
Okay, I'm just about to wind up. Thank you very much for your time. I really appreciate it. But I wonder whether there's anything that I've not really covered that you think is important, a message you'd like to get out to nurses who are working with people with mental health problems or learning disabilities.
I think what I'd say is, I mean, it goes back to your point about, I think good nursing care is the glue that holds healthcare together. But like the glue, sometimes it gets stretched and compressed in the whole process. And I think it's important to bear in mind that we as the CQC are interested in what good nurses are interested in. So we have common cause with the profession, which is about good quality of care for people, for patients, people who use services. And so I'd encourage staff to be as open as possible about those things, to talk about them and have the debate with their employers, with their peers, about what good quality care looks like, particularly at times where we know certain services are under pressure. And we highlight that in the Mental Health Act report, for example. And to speak out where there are concerns, but to do everything they can as well to improve the lot of their patients. Mental health nurses are natural advocates, and that's right and proper. And that's about helping people to recovery as much as it is anything else. So to see the CQC as a line, not necessarily an ally, no one should necessarily like their regulator. There should be an understanding of respect, however. The CQC's had some way to go in that. And the nursing profession is having a hard time at the moment. There's a lot of adverse publicity around nursing. But it's my belief as a nurse, as a regulator, that we're kind of in this together. So I would encourage nurses to do their best to improve the quality of care of their patients, and where they feel like they are unable to do so, to consider the necessity to let us know where the issues are, and if necessary to speak out.
Thank you very much.